Hello everyone. Today I will present the publication of Prognostic and Predictive Value of HER2 expression in Ductal Carcinoma in situ, results from the UK ANC DCIS randomized trial. HER2 is well-established predictive and prognostic biomarker, especially in invasive breast cancer. Around 20% of invasive breast cancer has HER2 expression. And ductal carcinoma in situ, or DCIS, showed to be HER2 expression around 40% in the previous study. However, HER2 is not routinely evaluated in DCIS, and the clinical significance of HER2 in DCIS is still remain unclear. This study aimed to determine the clinical significance of HER2 in DCIS by using the data from the UK ANC DCIS trial. This study was derived from the biomarker study subset, or BSS1, of this trial. The formalin-fixed paraffin-embedded tissues with HER2 expression analysis will be performed. All of clinical pathological details were used from the original trial. The study design was retrospective nested case control study. Here is the brief data on the original study. This is the randomized control trial in over 16,000 DCS patients who completely excised and show the negative free margin on histologic section. Patients were randomized into 4 arms, including of no treatment, radiation, tamoxifen, and combination of radiation with tamoxifen. The main primary outcome is the invasive ipsic retinal-based event, or invasive IBE. When compared to non-adjuvant arm, radiation and combination treatment show decrease in invasive IBE, but not different in tamoxifen arm. For combination treatment, the primary outcome is comparable to radiation alone, while showing the beneficial than tamoxifen except the contralateral event. These results demonstrate to the benefit impact of adjuvant radiation, and the combination therapy is not necessary. Back into this study, the BSS1 will examine the HER2 expression by the immunohistochemistry only. The HER2 scoring is based on ASCO CAP 2013 as 0 to 3 pass grading. Moreover, HER2 score that derive from digital image analyzer of HER2 staining in the tissue will be provided. However, the equivocal HER2 in DCS tissue will not perform the ERBB2 gene amplification because of old and different protocols of fixation, causing in situ hybridization failure to demonstrate the HER2 status. Basically, HER2 positive is defined as 3 plus, and the remainder was classified as HER2 negative. The clinical pictures and pathological details of the CIS will be explained and using from the pre-existing data. Case is referred to patients with recurrent disease, or IBE, and patients without IBE are control group. The case to control proportion is 1:2 ratio with the matching variable of age, treatment allocation, and follow-up time. The primary endpoint in this study is total IBE, and secondary endpoint are invasive and DCIS IBE. For statistical analysis, all of statistical value show a true sign of p-value. An improvement of predictive models demonstrated by the difference of chi-square value. Cruz-Colbert is testing for continuous and ordinal data. The time to recurrence between curves is determined by proportional hazard model with estimated hazard ratio. The 10-year estimation of recurrence is derived from reservoir analysis with Kaplan-Meier method. Furthermore, the sensitivity analysis is also performed by separation of the equivocal HER2 and the treatment allocation. For the results, this slide shows the consort diagram of the study. For the BSS1, 755 patients with FFPE tissue were separated into 4 groups according to the original trial. The subsequent case control study includes 543 participants with 181 of case and 362 control. The HER2 evaluation was analyzed in over 90% in each arm. For HER2 and clinical pathological details, if you see the pie chart, over 50% was HER2 negative, and around 2/3 was HER2 positive with about 10% of equivocal HER2 status. When comparing HER2 status to the clinical variable, the HER2 positive significantly demonstrate larger tumor size, higher grade, more necrotic tissue, and more inflammation. For HER2 status and recurrence, which is our interested primary outcome. When classify the HER2 as the binary outcome on the right column, you see the total IBE and DCS IBE is higher than HER2 negative, about twofold. Moreover, the sensitivity analysis by separate equivocal HER2 also demonstrate the similar results on the middle column as at the T level of HER2. However, it is not different in invasive IBE. These two Kaplan-Meier curves illustrate the if steroid recurrent by HER2 status again. The DCIS IBE in HER2 positive is higher, about 294 than HER2 negative, while the invasive IBE was the same between HER2 status. The HER2 score also associated only to total and DSS IBE, likewise to ISC grading results. When looking into the detail of HER2 status and type of recurrence, overall, HER2 positive DCIS show more recurrence with predominance of DCIS type. In contrast, HER2 negative DCIS has lower recurrence, but if the recurrence occurs, the invasive recurrence was more pronounced than HER2 positive DCIS. For multivariate analysis and comparing to the IBE, the binary category of HER2, rate of incomplete excision, and slightly larger tumor size were significantly higher rate of IBE. Contrastly, the radiation found to be decreased in list of the IBE, but not for tamoxifen. All of statistical values change very little from its univariate analysis. If divide HER2 into 3 levels, all of multivariate analysis results also still be the same for IBE. Furthermore, the sensitivity analysis in the case control study were similar in terms of HER2 status correlation to the recurrent events. The HER2 status also provide the improvement of predictive model by increasing of different chi-square value after sensitivity analysis. This confirms the prognostic property of HER2 in DCIS by ruling out treatment-related confounding. For HER2 and radiation or radiotherapy effect, interestingly, both of HER2 status DCIS patients significantly received the benefits in reduction of total IBE. In HER2 negative show 53% reduction of IBE, and for the HER2 positive DCIS on the right side demonstrate much more impact, almost 80% risk reduction from IBE after radiation. Looking into details more on radiation and IBE. Total IBE show the beneficial effect of adjuvant radiation in both of HER2 status, as previous slide mentioned. For the invasive IBE, the radiation only significantly reduced in HER2 negative DCIS. Finally, the adjuvant radiation show much more benefits in reduction of DCIS IBE in HER2 positive cases. For discussion, HER2 status of DCIS was demonstrated as the prognostic biomarker to indicate the natural cause of disease. If HER2 positive occur, the more severe tumor characteristic and the higher recurrence rate will be happen. HER2 also show the predictive effect after treatment with adjuvant radiation, as shown on the previous study. This study has several strengths and limitations to be addressed. The advantage include of the first largest biomarker study in randomized controlled trial, have well randomized treatment allocation and long follow-up, and also perform sensitive analysis within the case control study. However, for the limitations were result from the selection bias because of study design that selectively choose only the FFPE tissue available patients into study. That was allowed 45% of the whole original study. Moreover, the proportion of high-grade DCIS was higher than the remainder of the study and other datasets. Next, the ERBB2 amplification was not available in equivocal HER2 that may underestimate the prognostic effect. Moreover, there was no estrogen receptor data that might interfere to tamoxifen-related outcomes. Finally, is the lack of formal calculation of study power. In my opinion, I suggest to perform another prospective study in DCIS with pre-stratified HER2 status by complete evaluation of HER2 result in all patients and ERBB2 amplification analysis in equivocal HER2 with the result of estrogen receptor should be analyzed in all participants. In conclusion, this study results can ensure the recommendation of routine HER2 status assessment in DCIS patients because of the prognostic and predictive performance that demonstrated in this study. Thank you for your attention.